we may have to face emergency issues and for purpose if we are referring a patient without stabilized meeting. In such a context, IAP Alappuzha is very proud to have a academic session today with Sheeja Madam as our faculty.
You got to exit.
Coming.
So sorry for the delay. And now, without wasting much time, we would go into our academic session today. And before starting our today's academic program, I would like to invite Dr. Rojos, the President of AAP Kerala, for his felicitational address. Over to you, sir.
Thank you, Dr. Sri Prasad, Dr. Ansha, Secretary of AAP, and our National EB member, Dr. Annie Wilson. Today, the esteemed faculty, Dr. Sheeja Madam from SAT Trivandrum, and all the senior members like Dr. Harikumar, Dr. Indu Madam, Dr. Swinu John, and those who are joined from inside Kerala and outside Kerala. So now already around 120 faculties, delegates are joined to the program. So we can assume that this topic, what is the importance of the topic today to discuss. The snake bite is also, so it's very important topic to discuss too. And there are a lot of dilemmas and management issues regarding the snake bite is concerned. So I think the apt patient today, to discuss the scientifically regarding the snake bite, how we should manage when you come across the day-to-day management. So it is can occur in any level, even the tertiary level, in the primary level, in the local remote area. The one of things going to happen. So everyone should be aware what have to be do the basic things to our snake bite and how to proper management. Already everybody knows there is a lot of issues will come up for us when you manage any management is the problem with the snake bite is concerned. So I think we will have a very good academic piece by Dr. Sheeja Madam. And today the delegates are joined from inside Kerala and outside Kerala is also joining. So there is a very important academic venue here. It is great. I wish all the best for AAP for academic session and wish you all the best for the program. Jai Hind, Jai AAP. Over to Dr. Sri Prasad.
Dr. Annie Wilson, it's your turn.
Good evening, all. Dear President Dr. Sri Prasad, respected State President Dr. Rojos, our beloved speaker Dr. Sheeja Sugunan, and my dear friends in IAP. Snake bite is always a dilemma for a practicing pediatrician in peripheral institutions, and whether to give or not to give, whether to face the complications and better to refer, we are always in a confusion. And to enlighten us in this topic, we have a very good speaker, eminent speaker, and other than Dr. Sheeja Sugunan. And I think I'll not stand in between you and Dr. Sheeja. And I would take this opportunity to say that all the programs of AAP Kerala are going in a full swing, and we are left with a few more programs which will be starting when the schools are opening next month, like diet program and all. And at the end of the tenure, I think our flag will fly higher in the unity of states in India. And over to Sri Prasad for continuation.
Thank you, sir. Sheeja Madam, are you there for HOD of Alappuzha Pediatrics? Sheeja Madam.
I don't think Madam George
Madam, just before starting your academic session, I would like to Kiran, who is having an experience with the management of a snake bite case when he was working in Kerala State Health Services. He is currently doing his PG in AAP Medical College. Kiran?
Yes, sir. Yes.
Are you there?
Yes.
I think Sheeja madam knows him, familiar to her also. Kiran?
Yes, sir. Hello, sir.
Kiran?
Sir. Hello.
Now you are audible. Please share your experience.
Okay, sir. It was while
Kiran?
working. Hello, sir.
Kiran
Yes, sir. Yes, Kiran.
Audible. Continue.
Sir, it was while working in Kannur, Taluk Hospital, Peravur. We got a child of 10-year-old, probably neurotoxic environment. He presented with a following snake bite. He reached the casualty within 10 minutes and he presented with ptosis, abdominal pain and vomiting. And luckily we have a stock of ASP in our casualty, and we immediately started on this ASP. And it was after giving ASP, it developed anaphylactic and shock. Then we managed with IV fluids and all, given adrenaline. Then we stabilized him, and BP was and vitals are stable. And during that period, the government of Kerala started 108 services, and we with all incubation and with language coconut wall facilities, we referred the child accompanying one doctor to the Career Medical College, and child is survived. That was the incident, and actually it was the first time in that hospital we given the ASP, and it was actually 3 to 4 days that one incident is happened in Wayanad. Because some child is got a snake bite from school, and he got succumbed to death. A lot of debates are happened on social media about that. Whether to give ASV in a primary center or refer the child. That was the debates and all. ഇപ്പോൾ പബ്ലിക്കിനൊക്കെ കുറച്ചുകൂടെ അറിയാം സാർ എവിടെയൊക്കെയാണ് ASP അവൈലബിൾ ആയിട്ടുണ്ടാവുക കാര്യങ്ങളൊക്കെ. അപ്പോൾ ഡയറക്റ്റ് ആയിട്ട് അവർ അവിടെയാണ് വരിക. അപ്പോൾ പിന്നെ ഫിയർ നമ്മൾ കൊടുക്കാതിരിക്കുമ്പോൾ അതൊരു പ്രശ്നമാണ്. ഇൻഡിക്കേറ്റഡ് ആണ് വി റിയലി നീഡ് ടു ഗിവ് എന്നുള്ളതാണ്. പബ്ലിക്കേഷൻ വന്നു കഴിഞ്ഞാലും പബ്ലിക് ലാപ്സ് അത് കൊടുക്കാതിരുന്ന് കഴിഞ്ഞാൽ എന്തെങ്കിലും
കിരൺ പറഞ്ഞത് സമയത്ത് PG കഴിഞ്ഞ സമയത്തായിരുന്നു. അപ്പം കിരൺ ക്ലാസ് കോൺഫിഡന്റ് ആയിരുന്നു. Nowadays he said that he's losing that confidence. Without wasting much time, now we are ready to listen you, madam. Actually, our problem is that our doctors are not that confident to give ASC in a peripheral setup. So we want to get some confidence through your words. Over to you, madam.
Thank you very much. Thank you, team IAP as well as team AAP for the opportunity. So Kiran, I am very well aware of his potential also. He was our PG doing a DCH with us, and I still remember him managing a very complicated case of snake bite way back then also. Like Kiran, ormile. No, so I think I'll go directly to the topic. Okay, so we go directly. I have included your image of that patient in today's talk. Not the patient exactly of the X-ray. So we'll discuss today.
Thank you.
So thank you for the opportunity. So we move on to the topic today. So management of snake bite, as already said, once again, the focus is on the snake because of unexpected or probably preventable mortalities. But let us see how we can do that. So we should know that estimated 1,25,000 people die every year due to snake bite in the world, and more than 45,000 deaths per year happen in India. So with that background, we do understand that this is a very, very important topic. So now let us see two cases. This was an 8-year-old child who was brought with abdominal pain and vomiting to a local hospital. At the casualty at admission, the child was febrile with a normal vitals, and child was sent for a USG abdomen, which was found to be normal, and child again visited the casualty back. It was in the daytime, in fact. And this time, but the child was having some breathing difficulty. The saturation was around 92% and was showing a tachycardia also. Immediately, oxygen prompts was started and the child was referred. It took around 2.5 hours for the child to, for us to receive. I still remember seeing that child, and child was brought dead to the casualty. There was another child, a 9-year-old, brought with a history of snake bite. At casualty, the baby was lethargic. There was a history of snake bite. Vitals were relatively stable, but the child was showing ptosis with breathing difficulty. So immediately this time, definitely it was not missed that it is a case of neurotoxic envenomation. The child was immediately referred. But unfortunately, instead of the child coming directly to the hospital, they went to a Veshahari. And from there, by the time we reached, it was 1 hour later, we received the child in cardiac arrest. Post-resuscitation, the child was on prolonged ventilator stay. CT showed severe anoxic brain edema. And finally, the child was discharged after 20 to 25 days of hospital stay. But only difference was that that child who was totally normal before the incident was going home completely crippled, bedridden, no face regard, no vocalization. And at the same time, we had another child referred who had presented again similarly in a local hospital without any fear, without any history of snake bite. The child had got up in the night with some breathing difficulty, taken to the local hospital, and for the breathing difficulty, child was offered nebulization. While being nebulized, the child collapsed, and while after she collapsed, they immediately intubated the child, called us up telling that it is a case of acute asthma, was collapsed following nebulization and was referred. So when the child reached, the child was having some moments, but I still remember that when I went to examine, the pupils were completely dilated and fixed. And when you went back to the mother and asked what exactly happened, the mother's history was the child was perfectly normal, but got up in the night, vomited once and showed some breathing difficulty. I asked, did the child walk to the hospital? She was 9-year-old. They had taken the child. No, they had carried the child to the hospital. Then what happened? When the doctor asked in which class she is studying, she showed with her hand that she's studying in fifth standard. That clinches the diagnosis. Why should a child with asthma not able to speak but at the same time not able to verbalize, but able to show it with the hands, the peripheral movements, that she's studying in 5th standard. So that gives you a clue that probably you're dealing with a snake bite. But the difference was the third child went back home perfectly normal 5 days later without any neurological sequelae. So what did we see in these 3 cases? First child, the diagnosis was missed and died on the way. Second child, the diagnosis was correct, but the child went back completely neurologically crippled. Third child, the diagnosis was missed, but the child went home completely normal. So keeping all this in mind, what we plan to discuss today would be what are the emergency first aid we can provide, what are the signs and symptoms, both local and systemic, how to ensure a safe transport, and of course, what are the complications that we commonly see with a snake bite. So clinical presentations, many times patient present with history of snake bite, then our job becomes easy. But remember, if the patient presents to you in a cardiovascular collapse or a bleeding of any form without a definite cause, if you have a child who's febrile, who's coming to you in shock, if you have a child who's perfectly normal, suddenly coming to you with hematemesis, yes, we may think of other causes of hematemesis, but please keep this also in your back of mind that it can be a snake bite also. Patient presenting with unconsciousness, paralysis, or respiratory failure, again, this has to be thought of. And nausea, vomiting, and abdominal pain is such a common symptom. How do we say that suspect a snake bite every time you encounter this? But every time you encounter an abdominal pain, yes, it can be a simple gastritis. It can be gastroenteritis. It can be a viral fever with gastritis. But it can also be something very life-threatening, like diabetic ketoacidosis coming with abdominal pain, snake bite coming with abdominal pain. In these situations, it's because of splanchnic hypoperfusion causing the abdominal pain. About abdominal pain, whenever you see, please take care of the vitals. See that there is no rapid 3D pulse, there is no tachycardia, no, the patient is not looking really pale, because these might be clues that you are not dealing with a simple abdominal pain, you're dealing with something more than that. So keep that also in mind whenever a patient you encounter. Now, what is the first aid that you should offer? And the WHO says that every time you have a snake bite, do it right. That is, reassure, immobilize, go to hospital and tell your doctor. So immobilization is very, very important. You should think that that particular limb where the patient has got a bite is fractured. That is what you have to think. Whether it is a lower limb, whether it is an upper limb, please ensure that immobilization is there, because the moment that particular limb starts moving, the muscles are contracting, the lymphatic drainage is good, the venous return is good, and you're going to have the snake envenomation faster. So immobilization is key. And you can also try pressure immobilization, especially if the transport time is more. If it's going to take more than half an hour for the patient to reach a peripheral for a major center, but less than 3 hours, then pressure immobilization, even though they are not great level 1 evidences for this, but you can definitely try. That is, you can keep a gauze pad, a thick gauze pad at the site of the bite and put a bandage there, not very tight, just a simple bandage with a reasonable pressure, so that lymphatic drainage and venous drainage is occluded and not the arterial drainage. And then definitely immobilize. You can also use a crepe bandage starting from the periphery to the center for pressure immobilization. Here again, it should allow you to pass your fingers through the crepe bandage. It should not be very tight. If you don't do any of these and simply refer the child, that's perfectly okay. Pressure immobilization is not mandatory, but tourniquet is completely contraindicated. Please don't tie a tourniquet, because as it can cause gangrene. And remember, if a patient comes to you with a tourniquet, please don't release it unless you're planning to give an ASV. And before you release it, it is also important that you ensure that an IV line is in place, because the complications that you anticipate while you're releasing the tourniquet is a massive envenomation leading on to a cardiovascular collapse or leading on to a respiratory paralysis. So both these things we need to be careful of. So if the patient comes with tourniquet and you are not planning to give an ASV, then refer with the tourniquet intact. But otherwise, please do not try a tourniquet. Similarly, do not apply anything locally, and always ask the patients not to do anything at the site of bite. Now, what are the steps? Once you've received the patient, what are the steps? First and foremost, definitely is to get a proper history, like where is the site of bite, if in case they know which snake has bitten, whether they have brought the snake, whether the patient has any local or systemic symptoms. Also ask for drugs which can contribute to coagulopathy, especially a heart disease patient or someone with a post-misk on an aspirin. All these you need to know. So ask for the drug history also. Then, of course, look at the local site, look at whether there is a fang marks, whether there is local reaction, whether there is bleeding, and also look for regional lymphadenopathy. Remember, a local reaction with a regional lymphadenopathy, tender lymphadenopathy, is a grade 1 envenomation. Similarly, look for systemic examination. That is, look for the pulse rate, see if you're not missing a tachycardia, see the respiratory rate is adequate, he's breathing well. Remember, a child with snake bite and a neurotoxic envenomation is not going to have a respiratory distress, grunt, or retractions. What is going to have is a decreased respiratory effort. So please note that. See if the BP, if there is a blood pressure fall, look for ptosis. And if it's a bigger child, even you can do a single breath count and look for active bleeding and respiratory distress. And once you have done all this, see if the patient, they have brought the snake. How does the snake identification help you? The common snakes that we encounter is cobra, Russell's viper, crate, and saw-scaled viper. You have anti-venom for all these 4, but you don't have anti-venom for the hump nose pit viper, and that is the hump nose pit viper in the picture. You can see the upturned nose. That is one, and this is definitely poisonous. But for this, you don't have an anti-snake venom. But remember, don't touch the snake, even if it is a severed head, because a severed head can bite. And second is, please treat the patient and not the snake. Because even if you're bitten by a venomous snake, remember that 50% of the bites may be dry bite. So we have to look for envenomation and then only decide whether we want to treat or not. And from there, what is the test now you want to perform? You have looked for local signs, you have looked for systemic signs. And the one test that you would like to perform is definitely the whole blood clotting time. And if you are in a tertiary center, you can definitely do other coagulation studies like PT and INR and fibrinogen. Remember, even when the whole blood clotting time is normal, your PT INR may be prolonged. You can have vice versa also. That is, your whole blood clotting time is prolonged, but PT INR is normal. But depending upon what type of venom you're encountering, depending upon which anticoagulant, which clotting factor the venom really handles or neutralizes, your manifestations will be different. So in an ideal setup, it would be better to do a whole blood clotting time, PT-ANR, as well as fibrinogen. But most cases, whole blood clotting time is enough. You can send a blood routine to specifically look for leukocytosis and thrombocytopenia. Renal function tests and electrolytes are mandatory. And please do not forget to send for a creatine phosphokinase, especially when the local reaction is more, especially when the bite has happened in a muscular area like a calf. Because if the CPK is more than 10,000, the chance of rhabdomyolysis, myoglobinuria, and renal damage is high. And also, if you have an unexplained hypoglycemia persisting, do think of a hypopituitarism secondary to a hemorrhage in the pituitary gland. So now, let us see some cases and let us see what we can do. So this is a 10-month-old baby, not 10 month, 1.5-year-old baby who was brought to the hospital telling that there is a sudden change in behavior. Baby was playing otherwise normally, and suddenly the baby showed some abnormal movement. And thinking that it is a seizure, the child was given a lorazepam and referred. So now if you have a baby who has a local site of fang mark like this, and in case if the baby does not have any features of snake envenomation, local or systemic, is it okay to send them home? Remember, no child who comes to you with a snake bite should be sent home. Ideally, all of them should be kept under observation for minimum of 24 hours. And you should look for signs of envenomation, provide appropriate first aid, and ensure that the patient is nil per mouth till the patient reaches a tertiary hospital if you are planning to refer. Now, why should you not send a child home when you don't have any local or systemic side effects? The reason is because the signs of envenomation can appear as early as 15 minutes in a viper bite, or it may be as long as 24 to 36 hours. This 24 to 36 hours is rare cases. Most cases you will have signs of envenomation within 24 hours, and that is why an observation of 24 hours is mandatory. Now, also remember, when you look at the local signs of envenomation, it is not necessary that every bite will be painful. It is not necessary that every bite will have a local reaction. Remember, crate bite is painless. If you have a local reaction which is causing edema, which is crossing a joint, which is increasing and involving more than half the limb, if the local reaction is causing an isolated tender lymphadenopathy in the same link, bleeding from the site and blister formation are all signs of envenomation. So as you can see, I had shown you the hand, the first hand. In fact, that particular film is of a baby who died due to neurotoxic envenomation. So it's important to understand local site alone will not tell you if it is venomous or envenomous or non-venomous. Crate bites, you often do not see a bite mark. So it's very important to remember that. The second case, you can see the bite is in the muscular area, and this child went in for myoglobinuria and renal failure. The third child, you can see there are multiple bites and blister formation by the time the child has reached the first hospital itself. So you're definitely dealing with an envenomous snake bite envenomation as far as this child is considered. So always look for systemic signs of envenomation, which not only includes coagulopathy, remember, thrombocytopenia, nausea, vomiting, abdominal pain, dizziness, hypotension, arrhythmia, ptosis, ophthalmoplegia, descending paralysis, acute kidney injury, and capillary leak syndrome manifesting with edema around the eyes are all features of systemic envenomation. The whole blood clotting time is not the only thing that tells you that there is systemic envenomation. Neurotoxic symptoms are not the only thing that tells you there is systemic envenomation. Any symptom involvement is a systemic envenomation. And the most important test that we commonly do to pick up a hematotoxic bite is definitely whole blood clotting time. Here, and when you remember, if it does not clot or if there is a clot lysis, both means that there is a hematotoxic envenomation. But remember, whole blood clotting time has a sensitivity of 75 to 85% and specificity of 90 to 95%. So it is not 100% sensitive. It is not 100% specific. That is also we need to know. It may be missing milder forms of coagulopathy. All severe coagulopathy, it will definitely pick up. So that is also important for us to understand. And usually we will do a WBCT hourly for the first 3 hours, then 3 hourly for the next 3 times, and subsequently we do 6 hourly till 24 hours. A word of caution as far as whole blood clotting time is considered: do not use plastic, polystyrene, or polypropylene tubes. Use ordinary glass tube. Do not use glass tube which is cleaned with detergent, because detergent will destroy the surface activation factor. It will not stimulate the Hageman factor and clotting will not happen. So any glass tube that is washed in detergent should not be used to look for the whole blood clotting time. When in doubt, you can use a control from a normal patient. And if you don't have a glass tube, you can simply use a vial of any antibiotic. Only thing is, wash it with normal saline and use it to check the clotting time. So that you have to take care when you're looking for the WBCT. Now, this is a child who's brought with history of snake bite with swelling and bleb at the site of bite. On top of that, the child also has hematemesis. Now the question is, does he need ASV? I think none of us have a doubt that this child has a poisonous snake bite, and the child is definitely showing features of envenomation in the form of spontaneous bleed, in the form of local reaction, in the form of regional lymphadenopathy. Now the question is, should we refer without ASV or refer after giving ASV? Then the question arises, as the esteemed faculty has already said, that is there a chance of reaction and can be prevented? Yes, when we say that ASV should be given, why do we say ASV should be given? Remember, when you're giving an ASV, spontaneous bleeding will stop within 15 to 30 minutes. The same way, the shock will get corrected in 30 minutes. The arrhythmia will resolve in 30 minutes. And if it is a cobra bite, even the neurotoxic envenoming signs will be reversed as early as 30 minutes. Yes, there are some factors which will take more than 30 minutes, like your blood coagulability may take 3 to 9 hours. If it is a crate bite, it is not going to be, whatever neurotoxicity happens, it will be there whether you give ASV or not. But there are certain things that definitely show improvement as early as half an hour. So that is the reason why we say that ASV should be given. So your patient has presented in hematemesis. If we refer the child without giving an ASV, the child will go into shock. The child's condition will worsen, child may present in a cardiac arrest in the secondary hospital. So that is the reason why we want an ASV in this child at this time. But also remember, ASV does not prevent local necrosis or local swelling. Just because you gave ASV, it does not mean that the local reaction is not going to be there. The local reaction will be there. And once you have given 10 vials of ASV, do not repeat ASV just because the local reaction is increasing. Because that local reaction is happening because of the local venom which is there, and it is not going to be neutralized by the systemic antivenom that you have given. Remember, ASV does not reverse renal failure. It does not reverse coagulopathy. In fact, the liver reverses the coagulopathy. And presynaptic envenomation also, ASV does not prevent a neuroparalysis or reverse a neuroparalysis. So this also we need to be kept in mind. So now we understand the importance of ASV. We also understand how beneficial ASV is for the child. But what is our concern? Our concern is, can ASV cause reaction? The answer is yes, definitely ASV can cause reaction. The reaction rate changes from batches to batches. It may be as high as 80%. So definitely it can cause reaction. But remember, IgE-mediated reactions are rare, because when you say that it is an anaphylactic reaction, that means the patient should have encountered the same protein previously. Only then he is going to have an IgE-mediated response. If this is a patient who has previously received ASV or has received any other anti-serum, like currently we have a child who gives history of receiving an equine rabies immunoglobulin previously and now presenting to you with severe reaction. Those could be reasons where an IgE-mediated anaphylaxis itself can happen. But most times the allergic reaction that you encounter is a complement mediated by IgG, or it is a direct antivenom stimulation of the mast cells. And you can also have pyrogenic reactions, which are not exactly anaphylactic reactions. It is because of the contaminants or the pyrogens which is present in the ASV. You can also have late serum sickness 1 to 12 days after giving an ASV, which may manifest as vomiting, diarrhea, lymph node enlargement, or arthralgia. What we are concerned about anaphylaxis. And when it is very easy for anyone sitting in a tertiary hospital to preach about anaphylaxis, but it is very, very difficult to manage, or very a tricky situation when you face a similar situation in a peripheral hospital. But so that asks the question, is there anything that we can do to prevent an anaphylaxis. Yes, there is something that you can do to prevent anaphylaxis, but remember, this particular thing that is being done is not going to prevent 100% of anaphylaxis, but you can, but it does decrease the incidence of anaphylaxis by 43%. So what is that? You can give an adrenaline subcutaneous. So this is preventive dose. This is not treatment dose. And the dose is half of the treatment dose. You're not giving 0.01 mg per kg or ml per kg. You're giving 0.05 ml per kg. That is, if it is an adult, it is 0.25 milligram. Normally, we know for anaphylaxis, we give 0.5 milligram. Here, the dose is half of it. It is 0.25 milligram. And it is given subcutaneously. Word of caution, please do not combine it with Avil and hydrocortisone. If you're giving Avil and hydrocortisone along with adrenaline, to prevent an anaphylactic reaction, in fact, it negates the action of adrenaline. So if you give hydrocortisone, it does not prevent an anaphylaxis. If you give Avil, it does not prevent an anaphylaxis. If you give adrenaline, it prevents. But if you give adrenaline along with Avil and hydrocortisone to prevent an anaphylaxis, in fact, the action is negated. So if you're using a preventive dose, please use isolated adrenaline. Now, the next thing that you have to understand that when you are, that is, the rate of administration of ASV has nothing to do with the incidence of anaphylaxis. But even all said and done, what we commonly do is we add 1 vial of ASV to 5 ml per kg of normal saline and start slowly. And then we add the rest 9 vials and give it over 1 hour. That is what we commonly follow. But studies have shown that whether you give it the ASV over 20 minutes or whether you give it over 120 minutes, the incidence of anaphylaxis remains the same. And if the anaphylaxis happens, the first drug that we should be giving is definitely adrenaline. So anytime you're planning to give or you're giving an ASV, load adrenaline and keep. Why hesitate? Load adrenaline and keep. You have all the time to decide what is the dose you're planning to give. And in an emergency, don't weigh the child and decide 0.01 ml per kg, mg per kg. You can use blanket doses. If it is an infant, it is 0.1 mg. If it's a child, it is 0.3 mg. If it's an adolescent or adult, it is 0.5 milligram of adrenaline. Load and keep it so that in case there is a sign of anaphylaxis, you can give it. And in anaphylaxis, always remember adrenaline is IM. So once you've given adrenaline IM, 5 to 10 minutes, there is no response, you can repeat adrenaline IM. After 2 to 3 doses, if the reaction is not getting solved, you can definitely start an adrenaline infusion. Do not hesitate in starting. It is a safe drug when it is given as an infusion. So we have to prevent, and if happens, we also said what we can do. And also hypotension is there. Please start an IV fluid. If the patient is having respiratory distress, please give nebulizations also. And before that, naturally, we will be stopping the ASV also. So now what is the dose of ASV? Whether you're giving ASV for hematotoxic bite, for neurotoxic bite, or for local reaction, the dose is 10 vials, diluted in 5 ml per kg fluid, given over 30 to 60 minutes. Now, what are the indications for ASV? Repeat dose after 1 hour of a 10 vial administration. After 1 hour of a 10 vial administration, if your child continues to be in shock, please give ASV. If the child still has spontaneous bleeding, we said initially, spontaneous coagulation time, whole blood clotting time will take 6 hours to get corrected, but your spontaneous bleeding stops in 30 minutes. So if by 1 hour the spontaneous bleeding has not stopped, that means the envenomation load is high, you need to give the rest of the ASV. And if the neurotoxic symptoms do not decrease by at least 50%, definitely give the rest of the ASV also. So normally, what is the dose of ASV? We already said the first dose is 10 vials, but subsequently, you check for whole blood clotting time only after 6 hours. Once you have given 10 vials of ASV, there is no rule for a patient who is not clinically bleeding, the clinical indication to repeat ASV. If there is no clinical bleeding, please don't check whole blood clotting time before 6 hours, because 6 hours is the minimum time your liver needs to replenish the clotting factor. The clotting factor has all been used up, neutralizing the snake venom. So you have to do a whole blood clotting time only after 6 hours. After 6 hours, if your whole blood clotting time remains more than 20 minutes, you have, earlier what we used to do, we will straight away give 15 vials. or we may give 20 vials depending on what your assumption of severity of envenomation is. But what is the current recommendation is you can either use 6 vials 6 hourly. That is every 6 hours, you will check the whole blood clotting time. If it is more than 20 minutes, you will give 6 vials, or you will give 2 vials 6 hours. So remember, in both high dose and low dose ASV, you're first giving 10 vials. It's only the subsequent doses you're deciding whether to give 2 vials 6 hourly or whether to give 6 vials 6 hourly. Now, what is the advantage of using this intermittent dosage is that one, this is a highly precious thing. ASV, remember, we are getting it from the animals, not a very good method of creating a drug. The next is it is costly. Sometimes you go for out of stockage is also there. The third is it doesn't mean that a patient who's having a bite will either have the amount of venom which can be neutralized by 10 vials or will have a venom which can be neutralized by 30 vials. There's always an intermediate in between them. So when you use this mechanism, this particular dose, you are ensuring that you're using the minimum dose that is going to be helpful for the child. That is why this is advocated. Another reason is that in case the venom is getting released from the site of bite, when does that happen? Either you have a tourniquet there, which was removed now, or you have a patient who was presented to you in shock. Because the patient was in shock, the amount of venom absorption was less. Now you have resuscitated the child, you have given you have given ASV, and ASV's action usually lasts for only 48 hours. So after 48 hours, if the venom is going to be released from the site of bite, you can still have coagulopathy reappear. So that is the indication why sometimes ASV is repeated subsequently also. So from there, now we move on to the next case. So this is a child who got up at the night, similar to the one we had discussed initially. But this child has reached our hospital. The child brought up in the night with abdominal pain. I already said why abdominal pain is a danger sign, and has one episode of vomiting. On examination, this is how the child looks. If you look at the child, you can make out. They felt that the child is drowsy, child was afebrile, there was no grunt or retractions. Respiratory rate was 20 per minute, pulse rate 124 per minute, BP of 90/60, her chest is clear, her saturation is 92 in a room air, for which you can see that someone has put a nasal prongs and the saturation has gone up to 94. So now once the saturation is 94, you are having a completely apparently normal vitals, isn't it? BP is normal, no, there's mild tachycardia, saturation is normal. Can we refer this child like this because the vital looks okay? Look again. What is your child doing? Is the child drowsy? No, your child is not drowsy. Look there, her eyebrows are acting. Why should a child drowsy's eyebrows act? She is trying to keep her eyes open. That is why her eyebrows are acting. Next, I have covered for patient identity, I have covered the mouth, but at least you can make out she's not able to verbalize. Why a child who's conscious is not able to talk? And most importantly, a child with a normal chest, they're not getting anything, no added sounds. Why is the saturation 92? So that is the most important thing. No child with a chest clear should have a saturation of 92. You're missing something there. And here, the reason why the hypoxia is happening is not because your lung is abnormal. It is because you are not breathing. You are having only 21% FiO2 air inside your lung. If I increase the amount of FiO2 by putting a nasal prongs, initially my saturation is going to go up. But if I refer the child like this, the child will 100% go for a respiratory paralysis and may not reach the next hospital alive. So in a normal chest child, if there is hypoxia, understand that it is type 2 respiratory failure. It is carbon dioxide retention. It is a respiratory muscle weakness for which the treatment is not a oxygen prongs or oxygen mask. The treatment here should be something else. Remember, neuroparalysis, in case of a snake bite, is a descending paralysis. Initially, there is ptosis. Remember the first child I said, she was not able to verbalize, but she was able to show with her hands that she is studying in 5th standard. That is because the muscle paralysis has not yet reached her extremities. It's a descending paralysis. First there is ptosis, then there is dysarthria, dysphonia, and then dyspnea, dysphagia, and paralysis. So it's important to understand that. So in this child, what do you need? If the child is not breathing, or there is a shallow breathing, support ventilation with a bag and mask ventilation. And the best method is naturally by putting an ET tube and sequiring and going with a bag and mask ventilation after the ET tube intubation. But many times what happens, you might know how to intubate. At the right time, you will not have the right size of the ET tube. You will not, the laryngoscope will not be working because we encounter such situations very rarely. And this happens even in medical colleges. When in emergency, suddenly you see, you will not get the bag, you will not get the ET tube, you may not get the laryngoscope, all this happens. So if you don't have a facility to intubate for whatever reason, the next option definitely is to put a laryngeal mask airway. It costs only 1,500 rupees. We can definitely take an effort to ensure that all our ERs do have an LMA in place so that in time of need, we can introduce the LMA, connect the bag and mask to the LMA, ambu, and refer the child to the next hospital. In case LMA is not available, then the option is definitely ambuing the child. If you have a harness, you can even fix the mask like this on the face and manually ambu, and don't refer the child to a hospital that is far from where we are working. So always safer for us to take the baby to the next hospital where the airway can be secured, intubate, and then refer to the tertiary hospital where you want the baby to go. So that's very important. And sometimes you have children who don't have these respiratory signs, but you are referring the child. In that, and the travel time is taking more than half an hour. That means even though right now when I'm referring the child does not have any local or systemic signs, I find it is safe and I am referring, then what can you do? But please tell the parents that the child can go in for a respiratory failure on the way. If you have any breathing difficulty, please show to the nearest hospital rather than rushing to the tertiary hospital. If you remember the first 8-year-old child I discussed in the beginning, in fact, that child was alive till Kadakutam. That is what the mother says. Kadakutam vare aval anangundairunnu. She was moving, but at that particular place, she had stopped breathing. She had stopped moving. They didn't understand she's not breathing. They understood that she's not breathing. She's become unresponsiveness. But the ambulance decided to again travel for another half an hour to reach the medical college. But by that time, the child is already dead. So that is also important, that what we tell the ambulance driver, what we tell the accompanying patient to do on the way. So that is also important. So now always when you're dealing with a snake bite, please look for the neurotoxic envenomation. Here you can see the first child. You may think that the child is sleeping. Here again, you can see minimal movements of the eyebrows. You can see that the child is not opening the eyes. You may think it is a neurotoxic. It is simply the child is keeping the eyes closed. But just look at the child. Just 20 minutes after the ASV is complete, he's completely opened his mouth and opened his eyes and looking around. So that is the beauty of ASV. If you are dealing with a condition where it is not a presynaptic neurotoxic envenomation. So what is the role of atropine and neostigmine? So this is one thing. In case of neuroparalytic bite, we can always give a trial of atropine and neostigmine. Remember, in all neuroparalytic bites, this is not going to be effective, where the venom acts in the presynaptic vesicles. If the venom acts on the presynaptic vesicle, the vesicle is damaged. Once the vesicle is completely damaged, there is no role for atropine and neostigmine. It's only when you have enough acetylcholine in the neuromuscular junction will a neostigmine atropine combination work. So once you have given atropine and neostigmine, observe for 30 to 60 minutes. If you find there is a response, that is 50% improvement in doses in 1 hour, you can continue to repeat neostigmine 2 to 4 hours. But remember, if you have a child with a neurotoxic envenomation, you've given atropine and neostigmine, the child did not respond, we need to intubate and connect it to the ventilator. Please do not continue with atropine and neostigmine. Because neostigmine is it causes siluria, a lot of secretions. You give an atropine, which causes thickening of the secretion. That's exactly the reason why you pre-medicate, one of the reasons why you pre-medicate. So when this deadly combination happens, the chance of tube block is very high. And we already said that this thing is not going to work if it is a presynaptic envenomation. And if your child has already landed up in the on the ventilator, that means that you're most probably dealing with a presynaptic toxin. So if atropine neostigmine has not been able to prevent an intubation, we should not be continuing that post-intubation. So now, from there, moving on to the next case. A child brought with history of snake bite with colored urine. It's very, very important to understand that the organ next affected in a snake bite is your kidneys. So support your kidneys from the time you meet the child. So ensure that volume status is maintained. So colored urine may be a concentrated urine. If you don't take care at this particular point, the patient may go for acute kidney injury. If the bite is especially in a muscular area, and if you have a CPK more than 5,000, remember myoglobinuria can happen. It can damage your kidneys. And remember, the colored urine can also be due to venom-induced hemolysis causing a hemoglobinuria. It can also be because of a hemolytic uremic syndrome. So a word about an orange colored urine because of myoglobin. So this child, you can see the bite is in the calf, in the muscular region, and you have an orange color urine. So here again, treat hypovolemia. The earlier recommendation is use 1.5 times the maintenance and ensure a good urine output. I would say when you're using a high volume, please be careful. If your child is already puffy and is showing evidence of capillary leak, don't overload him with fluids, because capillary leak syndrome is a very dreaded complication. But always ensure that your urine output is good. If the patient is having acidosis, do use bicarbonate to correct acidosis. Try to maintain a urine pH of more than 6.5. So how can you maintain a urine pH of more than 6.5 without giving 1.5 times maintenance? Remember, a normal saline maintenance at 1.5 times itself can cause urinary alkalization, because normal saline contains a lot of chloride. When the chloride in your body increases, your body tries to excrete bicarbonate, which causes urinary alkalinization. If you're using 1.5 times the fluid, there is no need to in fact add bicarbonate. But if you're not able to use that much of fluid, then you can always use isotonic bicarbonate. How do you make an isotonic bicarbonate? You can take D5 425 ml, add 75 ml of bicarbonate to it. That becomes an isotonic bicarbonate and can be used as a maintenance fluid. And this alkalization should continue till your CPK comes below 5,000. And also remember, myoglobinuria and renal failure is not the only reason. You can have direct acute tubular necrosis. Here again, it is supportive care, maintaining euvolemia, and AATN may take weeks to recover. So when you have this dirty brown urine, you should know that we are dealing with an acute tubular necrosis, which may be like oliguric ATN, or you can have polyuric ATN. Either cases, you have to maintain the fluid balance. Long-term outcome, remember again that 1/3 develop evidence of chronic kidney disease like renal dysfunction, proteinuria, and hypertension. And 5% of patients progress to end-stage renal disease. So every time you encounter a child with renal injury following a snake bite, and he has recovered completely when he's going home, but please keep these children under follow-up. At least they should come to us yearly with an RFT and a urine routine to look for proteinuria as well as BP, to see that he's not going for an end-stage renal disease subsequently. Now coming to the next case, 7-year-old boy was referred on day 3 after snake bite. Now what is the problem here? He's having bleeding from the bite site and respiratory distress. In fact, this child had received ASV 25 vials from the local hospital. And today, when you're checking his whole blood clotting time, it is normal. But he is having bleeding from the site as well as respiratory distress. So what are we dealing with now? What should be our thought? So if your whole blood clotting time is already normalized, that means the present symptom that the child has presented to you is unlikely to be a venom, unlikely to be the venom remaining in your bloodstream even now. Because what is the reason here? The urine output has come down to less than 1 ml per kg per hour. The child has gone for periorbital puffiness. The child is showing thrombocytopenia. Please do think of hemolytic uremic syndrome secondary to venom. So if it is HUS, then definitely you have to go for the supportive care of HUS. So that means, which would mean you would give a cryosupernatant or FFP therapy 10 to 15 ml per kg, plasmapheresis if there is severe microangiopathy, dialysis where involved. But remember, avoid giving platelet transfusion as much as possible, because it may worsen acute kidney injury. So if you don't have a pressing need to give a platelet, please don't give a platelet. It will harm your kidneys further. Now, what happened to our child? Child was taken up for hemodialysis with FFP transfusion. Respiratory distress had subsided. We were maintaining an input-output chart. He was having a urine output close to 1.7 ml per kg per hour. But unfortunately, after giving the second FFP, the child went in for pulmonary edema. When you look at a pulmonary edema requiring intubation, and what you found was severe diastolic dysfunction with asymmetric septal hypertrophy. That is venom-induced toxic myocarditis. So bleeding and neurological manifestations are not the only thing. You can have direct myocardial injury because of the toxin, which can manifest as a diastolic dysfunction, systolic dysfunction, arrhythmias, anything it can manifest as. This child was on ventilator for a prolonged time, required inotrope cycling, and all. I think for 2 weeks he was on the ventilator, but finally he went back home well, and on follow-up his heart was totally normal. So venom-induced toxic myocarditis usually has a very good prognosis. Now coming to the next case, another child. Just now we said a child who went in for respiratory distress was because of pulmonary edema, and this pulmonary edema because of cardiac dysfunction. This is another child who again had periorbital puffiness with respiratory distress 12 hours post-admission. Now what is the problem here? Urea is 56, creatinine is 1. So first thing that comes to our mind is definitely renal injury leading on to respiratory distress. But when you look at the urine output, it is 2 ml per kg per hour, and you can see an IVC is still variable. So if your IVC is variable and urine output is good, then the respiratory distress may be due to something else. And here you can see that his chest X-ray is showing pleural effusion on the right side. We thought it is a severe capillary leak. This was the case I said that Kiran had managed beautifully in the night, along with Dr. Riaz, who was on duty that day, and patient had presented with hematemesis on the way. He was bleeding at the time of receival, and so they had decided upfront to give not 10 vials, but complete 25 vials itself. And when you aspirated, it was in fact an hemorrhagic pleural fluid, and post-tapping, the child was perfectly okay. Means the respiratory distress had subsided. Now another child, the last case, 5-year-old boy with hematotoxic snake bite, referred on day 2 in shock on inotropes. The child also had a seizure with a platelet count of 12,000 and a PT-INR of 3.5. So in this situation, what you want to ask is, how late can ASV be given? If this is a child who has not received ASV previously, up to 1 week, if there is evidence of coagulopathy, definitely ASV can be given. But if this child has already received ASV and is showing an active bleed, especially with a seizure where you're suspecting that it may be a CNS bleed, what is the role for FFP and platelets? The answer is, give FFP and platelet if indicated only after neutralization of venom with ASV. Because only after ASV has neutralized the venom will your FFP and platelet be helpful. If you give your FFP and platelet before ASV, the chance of promoting DIC and causing further renal injury is very high. So that is a take-home message. But if you are dealing with a hump nose pit viper for which no ASV is available, you don't have any other option. You have to go for symptomatic management only. Now, when we looked at the investigation of this child, his total count was 20,000 with a 20,300 with a platelet of 20,000, PT-INR of 3.5, a GOT of 117, deranged RFT with an albumin of 2, and a severe acidosis with pH of 7.14. So we also need to know what are the predictors of adverse outcome. When you encounter a snake bite, what are the predictors that tells you that the patient may go in for mortality risk is high? It's a beautiful study done by Jayakrishnan sir from Calicut, where they found that one of the predictors was definitely leukocytosis. When you have counts 20,000, 30,000, 40,000, you understand that the envenomation is severe, chance of mortality is high. Presence of acute kidney injury, especially renal failure, especially at admission, may indicate an adverse outcome. Younger age at presentation, anemia, the distance walked after the bite is more, and capillary leak syndrome, all are predictors of adverse outcome. A word about capillary leak syndrome. What is capillary leak syndrome? If you have a child following a snake bite presents to you in shock, the cause of shock can be multitude. The cause of shock can be a hypovolemic shock because of hemorrhage. The cause of shock can be abnormal vasodilation, venom-induced. The cause of shock can be a cardiac arrhythmia or a myocardial depression. the cause of shock can also be a capillary leak syndrome causing hypovolemia. So when do you suspect? When you have a patient who is in shock, but at the same time has a puffy eyelid, or has respiratory distress, or has an X-ray like the previous one showing pleural effusion, we should think of capillary leak syndrome, which is characterized by with a high hematocrit, with proteinuria, with serum albumin less than 3, you diagnose capillary leak syndrome. And what is the reason why they develop capillary leak syndrome? It may be because of endothelial damage, cytokine activation, capillary basement membrane damage. And as I already said, any of these could be the reason why this happens, but the prognosis is very bad. The mortality is very, very high. So there have been several experimental therapies. There are no randomized controlled trials to tell you what exactly to do in a capillary leak syndrome. There are studies where they have used plasmapheresis, studies where they use steroids, aminophylline, IVIG, terbutaline have been used. The mortality can be 43 to 67%. And if hypotension is persisting along with capillary leak syndrome, they say that the mortality can be even 100% in some particular studies. Personally, we have often used steroids, especially methylprednisolone. We haven't really resorted to plasmapheresis and IVIG for capillary leak syndrome isolated. But recently, now people are more and more using IVIG as well as plasmapheresis. Now, how do you manage a child with capillary leak syndrome? The main thing is manage the fluid balance from the time the child arrives itself, maintain the intake-output chart, maintain adequate perfusion, don't over-perfuse, that is important. Early ASV is also important so that the venom-induced capillary damage would be minimized. Renal replacement therapy has a very important role, whether you are doing a scuff, a SCLED, or hemodialysis or peritoneal dialysis. That is a very important cornerstone in its management. And as I already said, steroids, IVIG, and plasmapheresis are all options with unproven benefit. So finally, the take-home message: every time you encounter a snake bite, please do a systematic assessment of local and systemic signs. Also think of snake bite when children present to you with unexplained altered sensorium, unexplained unconscious, unexplained shock, unexplained bleeding. Also, we should be thinking abdominal pain and vomiting. Think of snake bite. Always try to stabilize the child as much as possible, and always tell the patients about, especially the neurological side effects that can happen due to snake bite, and which may not be present while you are examining, which may appear on the way, especially if you are transporting the child to a place which is far away. But if the child has already has cytosis, remember, it's highly unlikely that the child is going to reach the next hospital, however near the next hospital is, without a respiratory failure. Because once the ptosis appears, the respiratory failure may be just seconds or minutes away. So once the ptosis appears, it's always better to take care of the airway and then only refer. Remember, even if you miss the diagnosis, if you stabilize the ABC, the chance of survival is more. Always take care of the kidneys, and fine-tuning management in a tertiary care hospital goes a long way, along with the help of other multi-specialties, which would include a cardiologist and nephrologist, to really see that the patient survives. Thank you.
Madam, for the details session. So, happy to highlight to the attendance also. So, there is no wonder that you are always a crowd puller. Whenever you are in my category.
Okay.
So I think there's one question. Adrenaline, will there any action when child anaphylactic shock? It is always IM. It is never sub-Q. I hope I'm sorry if I conveyed a wrong message. I said prophylactic adrenaline is sub-Q. Treatment adrenaline is IM. Because when the patient is in shock, if we give adrenaline in the subcutaneous route, it will take half an hour to reach the systemic circulation. So once anaphylaxis diagnosis is there, it is always IM, no doubt. But when you're using prophylaxis, it's not IM, it is sub-Q. Because why it is sub-Q? Because the child has come to you in coagulopathy. That is why you're trying an ASV. And at that time, when we give an IM adrenaline, the chance of an muscular hematoma is also there. And the child is not in shock. So even if you give subcutaneous, the absorption of adrenaline would be good. So preventive is always sub-Q, treatment is always IM.
What is the success rate for adrenaline in reversing anaphylactic shock?
What is the success rate of adrenaline in reversing anaphylactic shock? I'm sorry, I do not know the exact rate, but it must be, see, it reverses in 100%. That is what I would say. The only thing is, we need to know that adrenaline is not the only thing. So once the patient presents to you in anaphylaxis, because I haven't come across an anaphylactic death. I have come across multiple anaphylaxis in severe forms, but I haven't come across anaphylactic death. That means anaphylaxis can be treated. So only thing is that treatment means we are giving first dose adrenaline, patient is not responding, you're giving the second dose adrenaline, third dose adrenaline, simultaneously you're securing an IV line, starting an IV fluid, and then you will be starting an adrenaline infusion. The immediate hypotension is usually corrected by the adrenaline IM as well as the fluid bolus. So I haven't personally come across, to say, an adrenaline and an anaphylactic death as such when it is picked up early. When it is not picked up early, even in our own hospital, if there is a shock, anaphylaxis that is happening in the ward, if we don't resuscitate the child there and we pick up the child from there and take it to the ICU, we may lose the child. എവിടെ വെച്ച് anaphylaxis നടക്കുന്നോ അവിടെ വെച്ച് manage ചെയ്യണം. Don't put them on the ambulance. We will not get the patient back. So it's important that the first dose of adrenaline and subsequent doses should go at the site of occurrence. That's the only way we can salvage the child.
Discoloration പറയുമ്പോൾ bluish discoloration, red discoloration at site of bite. അതിനെ അറിയാൻ പറ്റുമോ?
No, if there is ശരിക്കും പറഞ്ഞാൽ നമുക്കൊരു ബ്ലൂയിഷ് ഡിസ്കളറേഷൻ വരുവാണെങ്കിൽ അവിടെ ഒരു ഹെമറ്റോടോക്സിക് എൻവെൻമേഷൻ തന്നെ ആവാനാണ് സാധ്യത. Then another reason why you may have a bluish discoloration is, imagine the bite is happening right on top of the blood vessel, which may have caused a bleed. But whenever you have a local reaction, we should always be careful that the chance of envenomation is more. Blister formation is definitely a sign of envenomation. And bluish discoloration may or may not be a sign of envenomation.
അല്ല, അപ്പൊ അത് കൊടുക്കണോ വേണ്ട എന്നുള്ളൊരു കൺഫ്യൂഷൻ ഉണ്ട്, അതുകൊണ്ട് ചോദിച്ചാൽ.
നമുക്ക് എഡിയമ ഉണ്ടോ 100% കൊടുക്കണം. റീജണൽ ഇപ്പൊ ബ്ലൂയിഷ് ഡിസ്കളറേഷൻ വന്നത് ബ്ലഡിലോട്ട് കയറിയത് കാരണമാണെങ്കിൽ നമുക്ക് റീജണൽ ടെൻഡർ ലിംഫെഡിനോപ്പത്തി കാണും. So if it is there, we have to give.
Okay, കുറെയൊക്കെ അവർ തന്നെ സ്ക്യൂസ് ചെയ്യുന്നത് കൊണ്ടും ഈ സ്കിൻ കളറേഷൻ വരാറുണ്ട്.
അപ്പൊ റീജണൽ ലിംഫെഡിനോപ്പത്തി വരില്ല. അതാ ഞാൻ പറഞ്ഞ ബ്ലൂയിഷ് ഡിസ്കളറേഷന് വേണ്ടി നമുക്ക് ASV കൊടുക്കാൻ പറ്റില്ല. കാരണം ബ്ലൂയിഷ് ഡിസ്കളറേഷൻ ഒരു മാനിഫെസ്റ്റേഷൻ, we cannot call it as a manifestation of local envenomation because it can happen due to multiple reasons. But if you have a regional lymphadenopathy, we have to give.
Now, are there any chances of sudden death followed by snake bite? Sudden death.
Yes, sudden death can happen in snake bite. The reason, I'm sorry, I use Malayalam in between. I'll continue with English. Somebody has requested that. So sudden death in snake bite, yes, it can happen. The reason is, one is when we are missing a hypoventilation. That is, we might be thinking that the patient is breathing, but in fact, the patient is accumulating carbon dioxide. And when the carbon dioxide goes above a particular level, suddenly the patient may, and the muscle also paralysis happen, the patient may stop breathing and you may go in for an arrest. The next is you can have a you can have a cardiotoxic envenomation, which can cause an arrhythmia and cause sudden death. I have come across SPT, VT, both due to envenomation. So that is also possible.
Any pre-medication prior to intubation?
Sir, a pre-medication prior to?
Intubation.
Intubation, okay. So usually when we are intubating, we are already intubating a child who is already in a neuroparalytic state. So sometimes you might not require a pre-medication. You can definitely directly go ahead and intubate. Because here again, it is a neuromuscular paralysis that is happening. If it is a child who's hypoventilating, has not really gone in for a complete paralysis, we can just use a sedative and an analgesic and go ahead and intubate. That means you may use a midazolam with a fentanyl or a midaz and morphine and then go ahead and intubate.
Symptoms that warrant immediate ASV administration apart from doses.
Sir, I didn't get the question. I think the sound is breaking.
Symptoms that warrant immediate ASV administration.
Okay, symptoms that warrant immediate ASV administration. Okay. we are always bothered about neurotoxic environment. When we have a local reaction, it's usually the children will reach alive. Nothing happens. I haven't really seen somebody collapsing on the way because of a hematotoxic bite. What we have encountered is patients collapsing because of neurotoxic environment. So if there is a ptosis, we have to give ASV, we have to secure the airway and then only refer. Even if you don't give an ASV in a neurotoxic bite, if we secure the airway and refer, that is perfectly okay. The second is if you have a child who presents to you in shock, who presents to you with active bleed, who presents to you with arrhythmia, ASV is mandatory. The third is if the patient has a local sign of envenomation without systemic signs, but your chance of referral is to an area which may take more than half an hour, it's always better to give ASV. And one more, if you are giving ASV, please don't refer with ASV running. We are expected, the guideline says that complete the ASV and then only refer. And on the way, the patient should not develop an anaphylaxis. So that is also important.
Maximum dose of ASV.
Maximum dose of ASV will range from 25 vials to 30 vials. It comes from the basic concept that the amount of venom that a snake can inject can be neutralized by 25 vials. So usually it is either 25 or 30 vials maximum, not more than that. But there are rare instances where we have gone above 30 vials, especially when after the whole blood clotting time has become normal. Again, it becomes abnormal with symptoms. We have used up to 40 vials also. But the recommendation is 25 to 30 vials.
ASV is
Single bite
5% dextrose or normal saline.
Sir, I didn't get the question.
ASV is mixed in 5% dextrose or it's in normal saline.
It's usually in normal saline.
A single bite mark only. Does it mean non-poisonous?
No, no. It can be poisonous. Definitely it can be poisonous because the fang might not have, and both the fang might not have touched your this thing. Only one might have come. So that is not the reason. As I said, the crate bite, the child with the seizure I showed with no local reaction. In fact, they did not give a history of snake bite at all. There is no local reaction also. The child has come to you in arrest, you have intubated, and in the ICU, when you're examining the child, what has happened to this child? Why such a, with no fever, nothing? And then you pick up the bite mark there. It was in fact a migrant laborer's child. So they used to sleep in the floor also. So probably they got bitten like that. So single bite, local site, it is difficult. Don't rely on local site reaction to say whether it is poisonous or not.
Raksar is asking, are we justified in giving ASV if there is signs of envenomation but no history of snake bite, no clear-cut history of snake bite? Can we give ASV if there are signs of envenomation?
Okay, that's a very good question. Very good question, because that is exactly what we encounter many things. But in those situations, like for example, I told you about the child who was referred, intubated from another hospital, suspecting that it is a fatal acute near fatal asthma going in for arrest. The patients don't give any history of snake bite. We could not locate a snake bite mark also. But then we counsel the parents telling that we don't have any reason why your child has collapsed. Clinically, we feel that it is a snake bite. Your child is not responding, not breathing, no spontaneous movement, pupils are dilated and fixed. But still, we feel that this is a snake bite. So knowing that the medication that we are going to give can cause reaction, but probably that is the only way we can salvage. And giving that, our order consent, we ask for the consent and we go ahead and give ASV. We definitely do that. When in doubt, we do give. Again, the line is breaking.
Anaphylaxis ASV prolonged. Is there
Yes,
any role?
definitely. That is definitely. But for example, I said about the child who's currently in our ICU. The child, they had started, in fact, ASV from the referring hospital itself, but unfortunately, because it developed the anaphylaxis, that was the reason why the child was referred. But after coming here also, in spite of giving adrenaline IM, every time we were starting the infusion, the child was going in for reaction. So we could finish the 10 vials only by today morning. So you can, definitely you can decrease the rate of administration, flow of administration and try to finish. But the idea is to finish it as fast as possible. But because the longer the time you take, the chance of sensitization is more. Remember, ASV, please don't do any skin test. The skin test may sensitize the patient and you may experience an anaphylaxis when you're really giving the ASV. So the best way to give the ASV is give upfront itself. So don't do any skin test for ASV 100%. Then I think some questions are there. I'll see. No, one question is adrenaline dose in children in case of anaphylaxis. I said it is easy to remember. For an infant, give 0.1 ml. For a child, give 0.3 ml. For an adolescent, give 0.5 ml. ml and milligram is the same. So that is very easy for us to remember. 0.1 ml, 0.3 ml, 0.5 ml. We have a vital chart where adrenaline dose is also mentioned. We had conducted an emergency care workshop for all the districts. So if anyone wants that particular sticker, I think you can approach them, NHM, they would provide you the sticker free of cost. If not, you can contact me. I'll give you the soft copy. Please take a printout and put it in your casualty so that in emergency, we can have a quick reference. That would include the adrenaline infusion dose also. Then how will we know it if it is anaphylaxis versus snake bite symptom? That's also a very good question, because there has been times when we don't really know what we are dealing with. When does that happen? If your child is showing a symptom which has a skin manifestation, there is no doubt you are dealing with an anaphylaxis. But if you are having a hypotension without any skin symptoms, means any cutaneous symptoms, I mean, no urticaria, no redness, you are definitely in a dilemma whether you are dealing with anaphylactic shock or you are dealing with a venom-induced shock. In that situation, we don't have any other option. We give adrenaline, we support the BP, and we go ahead with ASV, because it's difficult to differentiate between the two. It's a very, very important question someone has picked up. Dr. Baiju.
What about the presynaptic neuroparalysis and the hump-nose pit viper bite?
Hump, in fact, that's currently in the ICU is hump-nose pit viper. That is what the snake specialist says. But hump-nose pit viper, as I already said, that its venom cannot be neutralized by the antivenom that we have, because it does not contain the antivenom against hump-nose pit viper. Earlier, it used to people used to think that it causes mild envenomation, but now we know it causes severe envenomation. It can be coagulopathic. It does not cause neuroparalysis, but it can be coagulopathic. So in that situation, if the patient is not responding, then definitely you are expected to give FFP or a cryoprecipitate. One word about hump-nose pit viper, it usually leads on to a increases fibrinogen degradation product and causes a fall in fibrinogen. So more than FFP, cryoprecipitate may be a good option. You can use either you can use when it is needed. But also remember that studies say that 6% of time the species identification is wrong. So personally, I'm not good at identifying a hump-nose pit viper. I'm not very fond of seeing the snake itself. So whenever I find an envenomation sign, our decision is to go ahead with ASV, but only 10 vials. Subsequently, if it's confirmed it is a hump-nose pit viper, we don't repeat ASV. That's the only difference. But Jayakrishnan sir, if he's very confident of identifying the snake, so if he identifies, they usually don't give ASV. Then another question is BT-CT versus whole blood clotting time. BT-CT, no. I would say it is whole blood clotting time versus PT-INR and fibrinogen level. What is recommended is definitely whole blood clotting time. But in a tertiary care hospital, you can always send for PT-INR. You will pick up coagulopathy early. Often it needs to be a little more coagulopathic, only then you may get a whole blood clotting time. But remember, if it is a particular like fibrinogen deficiency, you may have a normal PT-INR, but the whole blood clotting time may be abnormal. So this thing is do a whole blood clotting time. That is what is recommended. If needed, you can do a PT-INR and fibrinogen also, not routinely recommended.
Ma'am, the whole blood clotting time frequency was like 30 minutes for the first 2 hours and 1 hour hourly for the next 4 hours, like that. It was initially I read somewhere. So
in fact,
how is it like?
You can follow either way, because every time a guideline comes, there is a small changes happening here and there. So you can monitor every half an hourly for the first 3 hours and then hourly, and then move on to 3 hourly and 6 hourly. And especially the frequency, especially when you have a local reaction, always hematotoxic bites usually have a local reaction. So when we have local reaction, you're suspecting envenomation, you can definitely do half an hourly for the first 3 hours. No problem with that. Definitely can be done. So one question is what to do if we are not proficient in pediatric intubation. I would say what we can do in that case is we can keep laryngeal mask airway. Laryngeal mask airway comes in different sizes. Size 1, 1.5, 2, 2.5, 3, 3.5. We needn't take the 0.5. We can store size 1, size 2, size 3, maximum size 4. That is enough. And when you look at the laryngeal mask airway, the weight band is written on top of that. So we don't have to remember or mug up to say that which size patient requires which size of LMA. It is already written. Less than 5 kg, 5 to 10 kg, 10 to 20 kg, it's written which LMA to be used for which child. So it is already written. And it does not require any expertise. What you need to do is you take the LMA and then you deflate the cuff, you apply a lubricant jelly, you stand at the head end of the baby and introduce it into the throat as far as possible as it goes. You can watch the YouTube for the correct administration of LMA. We also have photos which tells you exactly what to do, nothing more there. You will keep on introducing till it doesn't go further. After that, you will just inflate it back. It will slightly pull back. You can fix it just like an ET tube and continue with your bag and mask. But that procedure of insertion should be known, because once you're pushing down the LMA, your finger needs to be there to ensure that the LMA is not folding up, it is going down straight. So that is important.
Adults use LMA?
Definitely adults do can. Definitely. In fact, most of the anesthetists for short surgical procedures, they no more intubate, they use LMAs. So LMA can definitely be used. It costs 1,500 per piece. But I think it is a worthwhile investment. Definitely, it's a worthwhile investment.
Madam, is it mandatory to give prophylactic adrenaline in all cases?
We give because incidence of reaction is very, very high. I think it's close to 80%, definitely most of the time. So we definitely give adrenaline prophylactic.
Madam, are there any standard treatment protocols in government sector to follow in case of snake?
There is a 2016 guideline by the national government itself. And most of the things that I said is from the guideline itself. So definitely that can be followed. Written informed consent is mandatory or not. I would say it's always better to get a written informed consent. Always better. Because in today's era of litigation and patient violence, it's always better. But I always believe that nobody denies a consent. It all depends on how we present it. So when we say that your child will die without giving this, the child can die while giving this also, but I'm giving you a chance of survival. If I'm giving this, no patient will say don't do. So how we present it decides. So definitely get an informed consent. Like today also we had to shift a child for imaging. So we were really scared that the child can arrest on the way. So we tell the bystanders exactly that. See, your child may arrest on the way. When I'm going for imaging, the child can go in for a cardiac arrest. But if I want to see whether I can do something more for the child, I need this. The same thing applies to ASV. You can always say, I'm giving ASV because your child is showing features of envenomation. Your child may not reach alive in the next hospital. But when I am giving this anti-snake venom, your child may collapse. I do not know. I will try my best to save your child. They will agree. So consent and the way we present is very, very important.
Madam, what is easy to manage, hemotoxic or neurotoxic?
Hemotoxic. Neurotoxic in the sense it is easy to manage if once you're ventilated. Once you're ventilated, you don't have to bother about anything. Only ensure that your patient doesn't go for a tube block. Hematotoxic is the one which goes for other complications like renal failure, capillary leak syndrome, all that thing is there. That is the one which really causes. But neurotoxic, immediate stabilization if it is appropriate. That means I would say from the point of a peripheral hospital, hematotoxic is easy to manage. Because even if we don't give an ASV and refer, the child usually reaches well to the next hospital, unless the child is in hypotension or unless the child is having arrhythmia. But always remember, there are bites which causes both hematotoxic and neurotoxic. So just because you got a hematotoxic, don't think on the way neurotoxic envenomation will not appear. So if you have signs of envenomation, please give ASV and refer. That is possible. And I said, get an informed consent. Why do we need to take a risk? But we need to salvage the patient also. So get an informed consent and give ASV.
Hydrocortisone avile paranjallo, madam already paranju. No role.
I think someone has raised a hand, Vivo 1920.
So any more questions? Audience, you can unmute.
One question in the chat box, how late can we give ASV?
No, I said there is no time limit to late. If anyone with a snake bites come to you with coagulopathy, however late it is, we can give ASV. No doubt about it. They will not manifest very late. No? They will come within 4-5 days itself, definitely. But if it is there, we can definitely give.
Madam, all blood result, Viper hematological, neurotoxic, all blood result difference.
Pure neurotoxic bite, we will not find whole blood clotting time will be perfectly normal. It will not be abnormal. In Viper, so that is the difference. In Viper bite only, we are going to have an abnormal whole blood clotting time. In Cobra, we will not see.
Snake bite depend result.
No, whole blood clotting time will only ensure that it is not a hematotoxic bite. That means at present, it is not showing any hematotoxic envenomation. I can safely refer the child. No problem. But when you are referring, we need to document the vitals, the respiratory rate, the heart rate, the BP. At the same time, tell the bystander that on the way, if there is a respiratory difficulty, don't wait. Please go to the nearest hospital. That is one message we have to pass. Because we do not know what we are dealing with. So every time we are referring a suspected snake bite, always tell them on the way, if there is a symptom, please drop in at the nearest hospital, which is possible. Right now, I am not finding any symptoms for me to give you a first aid. So that is why I am referring. We can be open with the bystanders.
How late can anaphylaxis of ASV present? How late?
How
can
late?
anaphylaxis of ASV?
That's also a good question. Normally, anaphylaxis to any drug presents mostly within 20 minutes, maximum within 4 hours. The late phase of anaphylaxis may manifest later after 6 hours also. IV administration of any drug which causes anaphylaxis usually happens within minutes. Even though we classically say that anaphylaxis can happen up to 4 hours, but usually anaphylaxis to an ASV will manifest while the ASV is on flow. Maximum 20 minutes after, even though theory says 4 hours, but usually you will see early. But always remember, once a patient has an anaphylaxis, you have treated the anaphylaxis, be careful for the secondary stage. That is, a late phase can appear after 6 hours also.
Madam, again, Dr. Baiju is asking, can we refer if it is neurotoxic and no symptoms of envenomation? Can we refer if it is a neurotoxic?
Okay, I understood. But that question, I think, arises in the fact that you have identified the snake. You know that this is a neurotoxic snake, but the patient right now does not show any features of neuroenvenomation. That's what I understand from the question. Because if the patient already shows features of neurotoxic envenomation, naturally we have to give ASV. But if imagine they have brought a snake, it is crate, you have seen that it's a crate, but the patient right now does not have any ptosis, he's breathing normally, you don't find anything abnormal, you can refer without giving ASV, because 50% of poisonous snake bites are non-venomous, dry bites. But just because the snake is poisonous, you cannot say that the patient will show features of envenomation. So we are absolutely safe in referring a patient who has had a poisonous snake bite but does not have any features of envenomation. There you don't have to give ASV.
Madam, is it mandatory to refer our patient after administration of ASV to a medical college?
No, not necessary. Definitely not necessary. Only thing is, after ASV, we need to continue monitoring. That's all.
How long we could monitor? How long? How long?
How long we monitor? But normally, after, if it's a hematotoxic bite, and that is the reason why we have given an ASV, Then after 6 hours, we will be looking at the clotting time. If the clotting time is normal, there is in fact no need to go on repeating clotting time, because if the clotting time is normal, that means there is no more snake venom there. Your body, your liver has already synthesized all clotting factors and it is not getting neutralized. So after ASV, after 6 hours, if the clotting time is normal, no further monitoring of clotting time, unless there is a clinical indication. That means if you have a bleeding from the bite site or something, any clinical indication you can do, because it might be an HUS setting in or not. The next is monitor the urine output and monitor RFT to see that you are not moving in towards the renal failure. Clinically see that the child is not puffy, child is not showing any respiratory distress, any symptoms on noka. If it is a pure neurotoxic bite, you have given your ASV and the child is normal, rest assured it is a happy ending.
So thank you, madam. In anaphylaxis, if hydrocortisone negate the effect of adrenaline, is it contraindicated?
No. I think a confusion I have created. Please understand, when I said pre-medication, as a pre-medication, it is adrenaline alone, no hydrocort with adrenaline. Once anaphylaxis happens, first drug is adrenaline, second drug is adrenaline, third drug is adrenaline, fourth drug is hydrocortisone. Because this hydrocortisone is going to prevent the late phase of anaphylaxis. I said that there can be a second phase of anaphylaxis 6 hours later. That is what your hydrocortisone is going to prevent. So immediate management is with adrenaline. Subsequent management, you can definitely give hydrocortisone. There is no negating there. There the action is for that 6 hour later action, you are giving that. You can definitely give Avil also. You can give salbutamol. Once anaphylaxis sets in, everything that you want to do symptom elevation, you can do, but the first, second, and third drug is adrenaline. After that, you can give CPM, you can give ranitidine as a H1 and H2 receptor blockade, you can give hydrocortisone, everything is indicated. But pre-medication is adrenaline alone. It's only in pre-medication where we don't want the hydrocort to come there, not as a post-medication. I hope it's clear.
So thank you, madam. Any more questions?
I think one question is conditions where whole blood clotting time can be false positive. That happens, as I already said, if the glass tube that we have taken is contaminated or it is washed with soap solution. Any kind of soap solution, if it is washed, there will not be any clotting happening. So whenever there is a doubt, take either a new glass tube, if you have. If you don't have, take a new antibiotic vial, wash it with normal saline and use it to see whether it is clotting or not. You can always take a control. Another normal patient's blood can be taken and compare to see if the clotting is happening. So if there's no local reaction and you're having a prolonged clotting time, then always should be a doubt that maybe it is wrong. You can always recheck, no problem with
that.
I wouldn't recommend BTCT.
Whole blood CT available.
It is now. It's always better to go for whole blood clotting time itself. But I won't recommend, because bleeding time mainly it's a platelet function we are looking. So BT is definitely not there. And clotting time, it's the same. And that simply looking at the clotting at the site of bite, I wouldn't advocate. I would say go for whole blood. Every hospital will have a vial anyway. There should not be any reason why we don't have a glass vial. Antibiotics bottles is definitely there. So use that.
So thank you for a detailed session. Anisha, Dr. Anisha? Anisha, no?
Yes, sir. Okay, thank you, ma'am. It was an excellent and wonderful session as usual. And we had a house-packed audience of more than 200. And I hope all the queries were cleared. Already late. So we'll wind up the session. Thank you, ma'am. Thank you, Lord. And thank you all the delegates for attending the session.
Thank you, madam. Thank you. Thank you all delegates. Thank you, Dr. Anisha. Thank you.
Sir, GB, late.
YouTube live ഉണ്ടായിരുന്നു. ഒക്കെന്നെങ്കിൽ വീണ്ടും നമുക്ക് റെക്കോർഡിംഗ് വെർഷൻ ഒന്നുകൂടെ ഇടാൻ നോക്കാം. കാരണം പലരും ചോദിക്കുന്നുണ്ട്. So thank you all.
IAP കേരളയുടെ ചാനലിൽ ഉണ്ടാവുന്നുണ്ട് സർ
അതെ,
ഇതിന്റെ
അതെ.
യൂട്യൂബ്.
So thank you all. Good night, ma'am.